Okay, hi everyone. I'm just going to give us another 5 minutes to allow everyone to join, and then we can start at 8:05. Right, okay, so that's 8:05. We'll go ahead and start. Yusuf, are you there?
Yeah, ready to go.
Cool. So thank you everyone for joining for joining us today for another one of our sessions in the urology series with Mind the Bleep. Today's topic is going to be talking about the acute scrotum. So if we go to the next slide, please. Great. So just before we go ahead and start, I'd like to give out a quick message for one of our sponsors, and this is CPD-Me. So they've designed a cool application, basically, which you can use to log in all your teaching for your portfolio. And it's designed for people who are registered with either the GMC or the NMC or any other sort of healthcare professional in the UK. And you can find it on your Android and iOS apps. So Mind the Bleep have a discount. So if you're interested, you can get 50% off. Just use the QR code provided. And now I'll go ahead and hand over to Yusuf, who's today's presenter.
Cool, thanks, Zach. So my name is Yusuf. I am a CC2 in Paediatric Surgery in Aberdeen. Grant. So what we're going to talk about today is the acute scrotum, and the learning outcomes are the recognition of the acute scrotum, the differential diagnosis, and the management of acute scrotal emergencies. And this is quite an important topic because the acute scrotum is a common presentation to a variety of healthcare practitioners. It comes to primary care, to surgeons, pediatricians, general surgeons, urologists, pediatric surgeons, etc. So and presents to A&E obviously as well. So it's good to have an idea about what are the various presentations. So we'll start off with testicular torsion. So testicular torsion is probably the most important one you need to know about. It's an acute urological emergency. And the most common and relevant type is intravaginal torsion, and we'll delve into a little bit, but not too much detail about that. And it's essentially where you've got an abnormal attachment of the tunica vaginalis to the lower pole of the testis. So I'm not going to spend a huge amount of time talking about the anatomy, but if you remember, you've got multiple layers of the scrotum, and if you've got a high, narrow attachment of the tunica vaginalis onto the testis, then this can predispose you to having a torsion. Okay, so in terms of the epidemiology, so there's a bimodal sort of peak. So the first peak is in the perinatal period, and this is what's called an extravaginal testicular torsion, which is not going to be very relevant to most of you. And it tends to be identified at routine baby check. The one that's more relevant is the intravaginal torsion. And this most commonly occurs in pubertal boys, where there's rapid testicular growth during that puberty phase. And essentially it outgrows the very abnormal high attachment in some young people and predisposes them to a torsion. So you can see there around anywhere from age 12 to 17. By about 16, the incidence starts to drop. Okay, so a little bit more about the pathophysiology. So if you look at the diagram of the normal testis, you see you've got the spermatic cord and you've got the lining around the testis, the tunica vaginalis. And you've got a normal longitudinal lie, and the lie of the testis is quite important because if you've got an abnormal lie, you are more likely to develop a torsion. So if you look at the middle diagram, this is a picture of a torsion where you can see that the spermatic cord is twisted around. And essentially what that means is that you've got an obstruction to the arterial inflow and to the venous outflow to the testis. And obviously, if this goes on for too long, and we tend to get worried about 6+ hours, then there's a high risk of losing the testis and needing an orchidectomy. With an extravaginal torsion, it's essentially it's in the name, so the whole complex from outside the tunica vaginalis torts, and this has a different pathophysiology than the intravaginal. This is the neonatal torsion that I've touched upon, and usually we need to look at other reasons, such things such as testicular tumors. Okay, if there's any questions about that, Zach, just let me know and I can clarify anything.
That's fine.
Perfect. So I'll just continue to move on. So clinical presentation. So very classically, it's sudden onset, out of the blue, severe unilateral testicular pain associated with nausea, vomiting. The pain is radiating to the lower abdomen on the same side of the testis that's affected. You'll have erythema, you'll have swelling. And sometimes, and this is important, there'll occasionally be a history of trauma, and you'll have little kids in school, in primary school or whatever, kicking each other in the balls, and you can't dismiss it as just a bit of pain from the trauma, because sometimes the trauma is the sort of trigger for this to happen. So just bear that in mind in the back of your head. If there's a history of trauma, testicular torsion is a very important differential to have. The extravaginal is identified at routine baby checks, and you get an indurated marble-like swelling. And again, there's not as much urgency about that because the testis is already dead, and there's normally a different underlying pathology that you'll need to deal with. So on clinical examination, you'll have hemiscrotal erythema, and this is important because if you've got erythema that's spreading to the other side or into the perineum or the groin or the penis, you need to be thinking about different things, different differential diagnoses, and some of them are more benign than others. Particularly in elderly diabetic patients, you need to be thinking about Fournier's gangrene, necrotizing fasciitis, that sort of thing needs to be in your head. But with younger children who've not got any risk factors for any of that, things like idiopathic scrotal edema need to be in the back of your mind as well. We won't go into that too much. You'll get a high riding testis, that's very important, and you'll get loss of the rugae, which are the normal folds in the scrotum. And this is a clinical finding really to differentiate a torted testis from other testicular pathology that's less serious. You have loss of the cremasteric reflex. So it's important to just bear in mind where you're examining your patient. So the cremasteric reflex is essentially where you've had, if you stroke the inner thigh, you'll get a contraction of the cremaster muscle, and the fibers of cremaster attached to the spermatic cord essentially will pull the testis up. But if you're examining someone in a cold room, in a cold A&E examination room, you're not really going to be able to appreciate a cremasteric reflex. A good trick is to get the patients to cough, and if you can see movement of the testis upwards, then that's sometimes fairly reassuring. And you can also get swelling, which is a late sign, and it's usually because you've got a reactive hydrocele, and that means that this has probably been going on for quite a while, and you'd be really worried about the viability of the testis at that point. So this is some pictures just to demonstrate the differences between intravaginal and extravaginal torsion. So you can see the intravaginal one is what looks like a boy who's obviously got more developed external genitalia, and you can see that high riding testis and the loss of the rugae that I was mentioning before, and it looks like there's an abnormal lie. So if you look at the left testis, it looks like there's a more longitudinal lie as opposed to a more horizontal abnormal lie of the right testis. So this is strongly suggestive of testicular torsion. On the other side, you're seeing a neonate. It's a picture of a neonate, and you can see because they've got what appears to be a physiological phimosis, you can't easily see the meatus of the penis. You most likely won't be able to retract that foreskin, which is normal at that age group. But the interesting part is the right testis, where you've got an indurated, dark, and when you palpate it, marble-like testis. And this isn't viable. This isn't viable. So you need to look at underlying reasons for this. Most important being a testicular tumor. And this is the only time where imaging, radiological imaging, is really useful. because testicular torsion is a clinical diagnosis, and I can't stress that enough. Okay, so this is the next slide. So yeah, testicular torsion, clinical diagnosis. So that if you only take away one thing from today's lecture, it's that testicular torsion is a clinical diagnosis. You don't waste time trying to get investigations. And if you call up a radiologist to ask for an ultrasound scan, in most circumstances, they won't be particularly happy, which I completely agree with. So it's useful in the neonatal torsion because you want to exclude a tumor as the underlying pathology that might have caused this testicular torsion. But if you're fairly certain from a good history and a good clinical examination that the patient has torsion, then you need to proceed to surgical management. Okay, so the surgical management is essentially you need to do an immediate scrotal exploration. And there's various approaches. Classically, people used to sometimes do a midline incision in the scrotum, but we're moving away from that. Even general surgeons, so certainly in pediatric surgery, we almost certainly wouldn't do a midline incision. We would do a transverse incision over the affected hemiscrotum. And if you needed to explore the other side, you do another transverse incision, and these tend to be along the lines of the rugae, so they heal very nicely, and you make small incisions as opposed to making a very traumatic incision in the middle. And then you detort the affected testis. And what you do is you rewarm it with lots of warm swabs, and you're waiting for it to pink up again, especially if it's looking particularly dusky. But there's a possibility that it's not going to be viable, particularly if the time to surgery was quite prolonged, usually about 6 to 8 hours plus, in which case you'd need to do an orchidectomy. But if you've made it in time, you do an orchidopexy, which essentially means that you're fixing the testis. And the two most common techniques are, so what the urologists will do is something called a three-point fixation. And what general surgeons, particularly in DGHs or places where there isn't a urology service, which essentially means you suture the testis at 3 points into the surrounding fascia. What we do in pediatrics is we create a pouch in the dartos layer, and we put the testis in there and allow adhesions to form, and that actually fixes it quite nicely. You do have to explore the contralateral side and fix it. And the reason for that is that quite a high proportion of these patients who've had a testicular torsion will have had what's called the bell clapper deformity, which is where you have this abnormal high attachment, high and very narrow attachment of the tunica vaginalis on the testis. So if it's happened on one side because of this, it's more than likely to happen on the other side as well. So you need to go fix the other side. So yeah, delays of more than 6 hours dramatically reduce the likelihood of salvage. So this is why you don't waste time with radiological investigations. And if the timeline is very short with these symptoms and you've got any diagnostic uncertainty, then you will never be criticized for taking these patients to theater. Okay, so here's some pictures of what it looks like intraoperatively. So the neonatal one is interesting to look at, but again, it's not the most relevant one in the world for you, but it's obviously a very abnormal looking testis, which there may be something else going on there. I'm not too sure. But on the left, you can see that there is the testis is twisted around its axis, and you can see the spermatic cord is torted, and the testis is looking very blue and dusky. So that needs to be detorted and warmed up with swabs. And I'm not sure that particular testis is going to be viable, if I'm perfectly honest. Okay. So there's other differential diagnoses to bear in mind. Obviously, testicular torsion is the most important of them, because if you don't exclude it or deal with it appropriately, you're going to lose a testis, and that can be quite devastating. In most people, they've got another functioning testis, but for a variety of reasons. You don't want that to happen, physiological, psychological, so on. So another thing to think about, and this is really only a pediatric issue, is torsion of testicular appendages. Okay, so during embryological development, there's multiple vestigial remnants of the Wolffian or the mesonephric and Müllerian, which are the paramesonephric duct systems, which essentially lead to the development of the reproductive and urinary tract systems. And the most commonly affected is the hydatid morgagni, which is thought to be the embryological remnant of what would have developed into the fallopian tube in the boy before they became a boy, essentially. And it's a 2 to 15 millimeter long mushroom-shaped structure, which is prone to torsion. And essentially what happens is that this little testicular appendage torts on its own axis, and that leads to the release of cytokines and inflammatory mediators, which will cause hemiscrotal erythema, edema. You can get a bit of a reactive hydrocele. You'll get pain. Does this sound familiar? So it sounds quite similar to testicular torsion, and it's a very important mimic in the pediatric population. So you can usually differentiate them on clinical examination, and normally there's a more insidious timeline with this. So you'll tend to get a child who'll say that, oh, I started to have this pain a couple of days ago and it's been getting worse and worse and it hasn't gone away. And they only told their parents after a day or two because it's a bit embarrassing. And just because they may have presented with a torted testicular appendage on that particular instance does not mean that they couldn't come back in with the torsion. So you need to tell them that if they have testicular pain again, they need to come back in. But certainly on clinical examination, you'll normally have a normal lie, and they'll be focally tender in the upper pole of the testis near the epididymis, which is where this most commonly torted testicular appendage, the hydatid morgagni, is an Italian surgeon who discovered this or described this. So it'll be focally tender there, but the rest of the testis tends to not be tender, as opposed to testicular torsion, where the entire complex will be exquisitely tender, and the testicular cord or the spermatic cord will be quite tender as well, but you'll have no cord tenderness in a torsion of the hydatid morgagni. So this is just another thing to bear in mind, and we do see this fairly frequently. They are a mimic of testicular torsion, and we feel much better seeing these patients. So if you see a patient and you're not sure whether this is what's going on, just send them into the nearest appropriate pediatric surgery or urology or general surgery department, because they do need assessment by someone experienced in seeing these patients. Cool. So this is the blue dot sign that you classically see. So as I mentioned, you get this release of cytokines and inflammatory mediators when you have these testicular appendages tort on their own axis. And sometimes you'll get this blue dot sign where the scrotum is blue precisely over where this torted appendage is. But it is important to bear in mind that you don't always get this. So you can have a torted testicular appendage and not have the blue dot sign. In fact, the blue dot sign isn't super common. So I wouldn't rely on that to make your diagnosis. Okay. Another differential diagnosis to bear in mind for acute scrotal pain is Epididymo-orchitis. And again, you'll get an erythematous swollen hemiscrotum, but you will have associated lower urinary tract symptoms. And what you need to do is send off that urine for microscopy, culture, and sensitivity, and treat with appropriate broad spectrum antibiotics until you have your sensitivities back, in case you need to give different antibiotics. You do need to take a sexual history, and that's why this almost does not exist in prepubertal, non-sexually active children. And if it does happen to occur, children can sometimes get viral orchitis and things like this, which can be mimics of testicular torsion. But if they have a bacterial Epididymo-orchitis, then you need to think about whether they might have an underlying renal tract anomaly. So the first line investigation would be an ultrasound scan of the renal tract. Okay, so in summary, the acute scrotum is not an uncommon clinical presentation. It presents to primary care, A&E, and a variety of surgeons. And careful history and physical examination is all you need to make your diagnosis. Again, if you're not particularly experienced and there's any diagnostic uncertainty, then you do need a surgical assessment, because these patients might need to go ahead and have a scrotal exploration. So it's very important that you make your decisions quickly, because if you've got a testicular torsion, the viability of the testis is not very long. It's about 6 to 8 hours. So you need to get these patients to theatre very quickly. And other causes of testicular pain can be managed medically. So something else just to quickly mention that I've not touched on is that you can have intermittent testicular torsion. And so, and classically this will present as the testis will torse and you'll have pain, and then it'll untorse and it will settle. So don't automatically think that if the pain is settling that it's going to be something benign. There's a possibility that it is an intermittent torsion. So you need to bear that in mind. So again, if you're not very experienced in this, you need an urgent surgical opinion. Perfect. So this is quite a nice diagram. So that wraps everything up. So you get acute pain and swelling. If you have testicular torsion, again, it's a surgical emergency that needs intervention, usually within 6 hours. The Doppler ultrasound will demonstrate decreased blood flow, but again, we don't want to be doing ultrasound scans. We want to be taking these patients for scrotal exploration. And you'll get twisting of the testis and the spermatic cord, resulting in ischemia, because you've got that impaired arterial inflow and impaired venous outflow. Perfect. Any questions for me?
Great. Thank you very much, Yusuf. That was really useful. I'm just going to give you guys 2 minutes in case anyone would like to pop a question in the chat box, and I'll relay that to Yusuf. So I have a question here from Dean. Can someone still get a torsion even after an orchidopexy?
No. Very, 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 very unlikely. I've never seen it before. I've never heard of it before.
Right, okay.
Because the testis is fixed in place, so how is it going to twist around? It can't happen.
Okay. Anyone else have any questions they'd like to put in the box before we go?
I'll take it as a good sign if I'm not getting too many questions.
Right, okay. I think in that case, we'll move on to the next slide. Cool. So thank you very much, everyone, for joining. And thank you, Yusuf, again, for a great session. So this is the QR code for the feedback form. If you guys could go ahead and do that, and you can get yourself some certificate. Obviously, if you have any questions that you think of later on, feel free to email us on the address provided, and I'll be happy to send it across to Yusuf, and he can send you an answer. And make sure you guys join us next time. Next time session is going to be a discussion with one of the urology consultants in Aberdeen, and he's going to tell us about basically his experience as a consultant and how you guys can get into urology if that's something you'd be interested in. So thank you very much, and I'm going to pop the feedback link in the chat box for anyone who would like to go through that way. All right, have a good evening, and thank you very much again, Yusuf.
Cheers. Thank you.
Thank you.